¿Qué tal? Nos falta Eric y Poncho, que no son 12:03. Hoy que les damos unos 3, 4 minutos más, ¿sí? Y ahorita comenzamos. Ok, vamos a comenzar entonces el... Bueno, entonces, déjenme comparto el sonido de la computadora. Este es el resumen de cómo terminó la plática última que vimos, en donde la estimulación gisiana, ¿no? Las nuevas tecnologías, los marcapasos sin los leadless pacemaker y que es el tiempo que empiezan a salir ya estudios más controlados acerca de esto, ¿sí? el tipo de... revisamos también lo de resincronización cardíaca y lo de desfibrilación, las indicaciones de desfibrilación cardíaca. ¿Ok? Disminuir la complejidad, sí, mejorar la fisiología, necesita todavía incrementarse las capacidades de los electrofisiólogos o de los cardiólogos intervencionistas en la estimulación gisiana, ¿no? Muy bien, vamos a seguir la siguiente plática.
To acknowledge that we need to trade off some of the main outcomes in pacing therapy. That is the individualized patient outcome, the complexity of the implantation procedure for its broad applicability, and the sustainability of therapy. So it is time that we plan appropriate control studies based on the outcome to compare conventional and emerging new technologies, so that we can reach a patient-tailored decision-making towards a less is more or a more is more therapeutic decision. Thank you for your attention.
Good morning, everybody. My name is Frida Braunschweig, and I'm the Director of Cardiology at Karolinska University Hospital in Stockholm. I've been asked to address the question of what does one need to know about sports and driving in ICD patients. These are my declarations of interest. Living with an ICD is a real challenge, and therefore patients have an essential need of comprehensive information before implantation and during follow-up. It's mandatory that patients and their families are well informed about the different aspects of living with an ICD, and common questions concern aspects of daily life. How does the ICD affect my working and traveling? Questions of intimacy, interference with other technical appliances, questions of end of life. And then many patients are very concerned how the ICD affects their possibility to practice sports and to participate in traffic. These are two subjects that are immensely important to patient autonomy and to the ability to maintain a normal lifestyle. As there are some restrictions, these are also two topics that sometimes lead to great disappointment among patients, and therefore I think it's worthwhile to be addressed in this symposium. Basically, regarding both sports and driving, it's important to understand that restrictions, where they apply, are largely motivated by the underlying heart disease and not so much by the ICD itself. Patients sometimes argue, if I had known about these restrictions, I would not have chosen the ICD, but generally the ICD is just an indicator of severe heart condition. Clearly, in most circumstances, it would feel much safer to meet a patient in traffic who's protected by an ICD than the one who's not. Some distinctions are to make between primary, secondary prevention, leisure time, and competitive sports, private versus professional driving. Generally, to both sports and driving, we can state that there's a lack of prospective data, and recommendations are mostly based on expert opinion and public policy. There are two papers to mention. This newly published recommendations for participation, leisure time, physical activity, and competitive sports, and then a consensus statement on ICD and driving dating back to 2009. During this conference, the ESC guidelines on sports cardiology and physical activity will be presented, but the content is still confidential today when this presentation is recorded. Generally, physical activity is, of course, also recorded in ICD patients. However, we need some shared decision-making between patient and physician concerning the type and appropriate intensity of sport participation. Previously, ICD patients have been generally banned from competitive sports. However, today there has been a shift, and there's consensus that competitive sports may be considered in selected patients. There are some prominent examples from elite athletes competing in basketball, pole vaulting, and other sports despite having an ICD implant. There are safety aspects not only for the athlete but also for others, and ICD patients should not participate in motorsports or mountain climbing, for example, where they pose risk to bystanders. Furthermore, shared decision-making needs to consider aspects specific to the device and to the prevention of arrhythmias. This slide summarizes device-specific aspects. Contact sports with risk of direct trauma to the device or hematoma of surrounding tissue should be avoided. This extends also to rugby, boxing, and so forth. Other sports like soccer, it has been suggested to wear specific shielding or padding to protect the device. Sport activity should be considered when choosing the site of implantation, preferably contralateral to the dominant arm, like in tennis or shooting, and pronounced arm movement, like in discus throwing, volleyball, basket, and so forth, increase the risk of subclavian crush and lead damage. And ways to reduce this risk include the lateral vascular access for lead insertion. Post-implantation, it's recommended to pause training for 6 weeks, not to risk lead dislodgement or other early complications. Then it's important to adjust detection zones, upper sensor and tracking rates to ensure optimal cardiac performance during exercise and to avoid inappropriate ICD therapy for sinus tachycardia. Regular follow-up is done preferably via remote monitoring to identify potential risk for an inappropriate device activity early and to guide optimal programming of the device. Optimal management of arrhythmias is important, both atrial and ventricular arrhythmias, which can lead to hemodynamic compromise, syncope, and ICD shock. Medication is often not well tolerated, and therefore there's a very low threshold for ablation therapies. After an ICD intervention or VT ablation, the current ESC document proposes a 6-week interval without training. Recent publications from the ICD Sports Safety Registry have improved our knowledge about the eligibility of ICD patients for leisure time and competitive sports. In this paper by Heidbüchel and co-workers, 317 competitive athletes were compared with 80 recreational. No death or injury was reported due to arrhythmia or shock. There was similar freedom from lead malfunction and similar proportion stopping sports due to shocks in both groups. However, on the right panel, you see there was a significantly larger proportion of patients participating in competitive sports who received shocks both in total numbers and concerning appropriate and inappropriate therapy. So the conclusion was for recreational athletes with an ICD that they can engage in sports without severe adverse outcomes, unless there are other reasons to preclude continuation of sports activities. And this study has been published in Circulation, a long-term follow-up from the same registry, including 440 patients. You see here the main diagnosis and the main sports. Although there were, again, no death and no injury during sports, it needs to be considered that there was a substantial number of ICD therapies for ventricular arrhythmias during competition, during ordinary physical activity, and during rests. And there was also a substantial number of inappropriate therapies. In total, there was a clear increase of shocks during competition and physical activity as compared with rest. So it's important to inform patient and to remember during management of these patients that the risk of receiving shocks is increased when the patient participates in competitive sports. Then to ICD and driving, this is really a matter of balancing the individual rights and the freedom of the patient to drive a car against the risk of injuring or killing bystanders. There are ways to calculate this risk of harm and factors to consider: the time spent driving, of course, much larger in professional drivers, the type of vehicle with a much higher impact of trucks who are involved in more fatal accidents, and also the annual risk of events and the probability of accidents. In this example, a professional driver would have a 22 times higher risk to harm bystanders than a private driver. Therefore, there are different recommendations for professionals and for private drivers. This is from the 2009 consensus document. It's important to note that there are national recommendations which may deviate from this consensus paper. Generally, in professional drivers, there's a complete ban from participating in traffic and a permanent restriction in all aspects. Private driving with an ICD is allowed with specific restrictions after implantation, longer for secondary than for primary prevention due to the higher recurrence risk. Again, this may vary between countries, and in some countries the interval after primary implantation is even shorter than 4 weeks. After appropriate therapies due to the recurrence risk, it's also 3 months, and after inappropriate intervention until measures have been taken. Also, device and lead replacements trigger certain restrictions, while patients refusing primary or secondary ICDs are handled quite differently due to the high risk of repeat events in non-protected patients with a secondary intervention, a secondary indication. Unfortunately, many patients do not follow these driving restrictions, which likely has both a patient and a doctor component. This data from a Danish survey was presented at last year's ESC conference. It shows the proportion of patients who were driving within restricted periods. In blue, those who recall that they received information, and red, those who did not. Astonishingly, large proportions with primary and secondary preventive indications or restrictions after appropriate shocks were driving despite these restrictions, significantly more so if they felt not having received information. Very disturbingly, also a large fraction of professional and large vehicle drivers with permanent restrictions did not follow these regulations. This indicates a clear call to improve information about restrictions and patient adherence. In summary, physical activity and driving are important features of patient autonomy, and it's crucial that comprehensive information is provided. Physical activity on an appropriate level and choosing appropriate sports should absolutely be encouraged. Even participation in competitive sports may be considered after careful shared decision-making. Sport participation is to consider when choosing implantation site, vascular access, and the programming of the device. As to driving, professional driving is generally not allowed with an ICD, and certain restrictions apply even to private drivers after implantation and after certain events. Many ICD patients and probably clinicians are not aware of driving restrictions, and that needs improved. And I think we need more prospective studies to improve our knowledge and to inform future guidelines. Thank you very much for your attention.
Muy bien, cosas interesantes. Una de las cosas que yo no me había puesto a pensar, y ahora a propósito de el paciente o los pacientes que hemos tenido con exteriorización de la fuente de marcapaso, ¿no? ¿Será que obviamente no son atletas de alto rendimiento? Yo creo. Pero ¿será que el paciente, por ejemplo, el último, el que está ahorita hospitalizado, será que era diestro, utilizaba la mano derecha y lo utilizaba a lo mejor, no sé, para cortar leña o barbechar o no sé? Creo que es una de las cosas que no estamos interrogando a nuestros pacientes, ¿no? Y que pudiera ser una cosa importante. O sea, él no se ve todavía activo, ¿verdad? No sé qué opinan. Poncho, Ricardo.
Sí, doctor. Normalmente solo nos enfocamos en las complicaciones inmediatas y pues que se muevan los cables inmediatamente después de colocarlos, pero pues sí, también estaba pensando en el paciente que no hacemos las recomendaciones en el seguimiento a mediano y largo plazo. Y muchos de ellos pues sí vienen pues son trabajadores del campo y todo eso. Habría que equiparar en algún punto qué actividades se parecen a las actividades que nos pusieron aquí en la plática.
Sí, exacto. Una de las cosas que está faltando, Poncho, Ricardo, Bueno, todos, pero es hacer del manual de procedimientos, Poncho. Sí les voy a encargar que me redacten nada más la preparación de los pacientes, ¿no? También, fíjense, tenemos acá en este paciente una complicación, o sea, tenemos que tener el chequeo de que no esté recibiendo algún tipo de heparina, a menos que lo necesite, ¿verdad? Que hagamos nuestra hoja de check-up de la preparación para ser yo a un paciente de sala de hemodinamia. Y las cosas que podemos plantearle al doctor, hay que presentársela al doctor Leiva, Poncho, ¿sí?
Ajá.
Te lo encargo sobre todo a ti. Una de las cosas que podemos ahí agregar es las preguntas de qué tipo de actividad a qué se dedica. Si es un viejito que va a estar en la cama, pues bueno, no hay problema, pero si estamos teniendo pacientes que a lo mejor utilizan mucho el brazo del lado derecho, entonces pudiera ser un factor, así como puso este doctor, ¿no? Digo, los desfibriladores son aparatos a veces un poco más grandes, pero es una parte importante ahí. Entonces incluir esa pregunta y comentarla con el doctor.
Otra cosa
Leiva,
que es
sí.
el sitio de colocación, y eso también va relacionado en cuanto a la edad y la funcionalidad del paciente. ¿Qué tanto prefiere hacer una bolsa profunda a la colocación habitual infraclavicular por el riesgo de exteriorización? No es lo mismo dejarlo subpectoral que dejarlo luego en contacto nada más con la fascia y piel.
Sí, eso también te lo encargo, ¿no, Poncho? O sea, tratar de hacer unas preguntas de qué se dedica, edad, en los implantes de marcapaso, ¿no? Edad, a qué se dedica, qué horas utiliza, sí, para tratar de más o menos orientar hasta los implantes que sea un poco más profundo, ¿no? Como es lo que también comentaron aquí.
Ok, doctor.
Perfecto. Muy bien, vamos a continuar.
ESC is very important for my daily practice, especially with the impressive educational portfolio.
ESC has made a major difference. The communications, the guidelines, the papers, the publications, and particularly the e-media. You can get it on your iPad, your iPhone, your laptop. So I think we're improving our patient care.
The joy of the ESC is that you have this large group of like-minded people with a passion for cardiovascular disease and cardiovascular disease prevention, who are willing to walk the extra mile for patient care.
The ESC is not only a community, it's a family. One really feels one is part of a very, very large, the largest cardiology network.
The ESC has been very helpful. I have been able to contact with the leaders in the field of cardiology, and these leaders in the field have enriched my own career.
It's a big network. It's a great resource. It's great people that you have contact with that you can bring into teams.
I've been going to the ESC Congress every year, year after year, which is of course a very intense interaction. Experts, scientists, good friends you have made over the years where you can really interact on a very high level.
I am very proud to be a member of the ESC community. I was able to develop a very important network to share with colleagues ideas, projects, and knowledge.
Hello, my name is Deepak Gitecha from Birmingham in the UK on behalf of the RATE-AF investigators. It's great to present to you today on the final results of the RATE-AF trial, rate control therapy evaluation in permanent atrial fibrillation at the ESC Congress 2020 Digital Experience. My disclosures are listed on this slide. The trial was funded by the UK National Institute for Health Research. Atrial fibrillation places a huge burden on our health systems, particularly in older multimorbid patients. The increase of prevalence of AF is expected to dramatically outpace any rise in population, as you can see in this graph, doubling over the next few decades. This is not only due to an aging population, but also an increase in incidence of AF in older people. Although we seem to have made good progress over recent years for younger patients, the mortality remains stubbornly high in those who are most likely to suffer from AF, older patients. A few other salient facts. Firstly, although the vast majority of research in AF has been directed to those with paroxysmal and sometimes persistent AF, permanent AF, where the rhythm control is not planned, is the most common group of patients. In these patients, over half have heart failure or will develop heart failure. Heart rate control is the mainstay of treatment for these patients after deciding on stroke prevention therapy, but currently we only have short-term trials assessing the acute heart rate response, leaving the choice of therapy to anecdotal experience and observational data. If we look at the two main rate control options, beta blockers are commonly used due to their beneficial effects in heart failure with reduced ejection fraction. However, this mortality benefit does not appear to extend to those with AF in the double-blind randomized trials. Data on digoxin suffers from extreme prescription bias, as doctors typically reserve digoxin for sicker, older patients with more comorbidities. The grand truth is that in randomized trials, digoxin is also neutral with regards to mortality, although this is based on patients with sinus rhythm only. Although digoxin has been in use since 1785, we have no longer-term trials of digoxin in patients with AF or AF with heart failure. The RATE-AF trial was designed to answer this important clinical question using a probe design, randomized, open label, with investigator blinding of key outcomes. The study was developed and managed alongside a patient advisory team focused on the outcomes and processes of most importance to patients, and included patients with AF in need of rate control, aged 60 years or older, with breathlessness equivalent to at least New York Heart Association Class 2. Exclusion criteria were kept minimal to achieve a generalizable cohort, and importantly, we avoided any exclusions related to heart failure or ejection fraction apart from recent decompensation in the last 14 days. The primary outcome was quality of life relating to physical function at 6 months, with key secondary outcomes of heart rate, the Modified European Heart Rhythm Association symptom class, and NT-proBNP at 6 and 12 months, and then other quality of life domains, ejection fraction, and clinical events at 12 months. Due to the lack of prior data, we had an open two-sided hypothesis test for all of these outcomes. The protocol and design. Here you see the consort diagram for the trial. I'll make a few key points. Firstly, we met the randomization target of 160 patients, and these patients were randomized to digoxin or bisoprolol. patients with intolerance or adverse reaction to bisoprolol were permitted to use an alternative beta blocker. The groups were well balanced at baseline, with an overall mean age of 76 years and nearly 50% women, reflecting the true population well. AF symptoms in the majority of these patients were moderate or severe, and half had signs of heart failure at baseline, predominantly peripheral edema. The average NT-proBNP was above 1,000 picograms per mil, and 1 in 5 patients had an ejection fraction less than 50%. The number of deaths we saw was in line with expectations, and so the sample size calculation for the primary outcome was achieved. By 6 months, all but 3 patients randomized to digoxin were still on treatment, with a low dose approach evident and a mean digoxin dose of 161 micrograms per day. Vital status was known for all patients, and only a small minority required additional rate control drugs when these were given time for these medications to work. Here you see the heart rate response. Heart rate was around 100 beats per minute in both arms at baseline and reduced to a similar extent with low-dose digoxin and beta blockers. No patients randomized to digoxin required pacemakers, and a third had pauses on 24-hour tape, although the longest pause was of a similar duration to that seen in the beta blocker arm at around 3 seconds. The primary outcome of physical component quality of life increased from baseline in both groups, with no significant difference between digoxin and beta blockers. You will note the substantial reduction in quality of life across all of these domains compared to the norm for these patients, and also that over time, quality of life across these different domains continued to improve with digoxin, and in several areas such as physical function, vitality, and global health, digoxin was superior to beta blockers by 12 months. AF-related symptoms were consistently improved with digoxin compared to a much more mixed picture with beta blockers. You can appreciate here the substantial number of patients who received digoxin that reached either no or only mild symptoms. In a pre-specified analysis of those with a 2-class improvement in the modified error score, over 50% of patients had a 2-class improvement with digoxin at 6 months, and the difference compared to beta blockers remained at the 12-month period. Heart failure outcomes such as NYHA class were improved with digoxin more so than with beta blockers, and NT-proBNP reduced overall at each time point. In contrast, NT-proBNP increased with beta blocker therapy, and the comparison with digoxin was significant at 12 months. Despite a number of patients randomized to digoxin stopping their beta blockers, we saw no compromise in left ventricular function, and in fact, both groups had a similar improvement in ejection fraction over 12 months. Now, RATE-AF was not designed to detect a difference in clinical events. However, we did pre-specify a comparison of adverse events. As you can appreciate on this slide, patients randomized to digoxin had substantially and significantly lower rates of adverse events, 29 with digoxin compared to 142 with beta blockers. In contrast to prior observational data, we saw no increase in deaths with digoxin, and in fact, independent adjudicated cardiovascular events were only a fifth that were seen in the beta blocker arm, and a half the number of unplanned hospital admissions and serious adverse events with digoxin. We also saw a lower healthcare utilization, in particular visits to general practitioners for either atrial fibrillation or other cardiovascular symptoms. In summary, the RATE-AF randomized trial has demonstrated that digoxin therapy in older patients with permanent AF and symptoms of heart failure has a similar effect as beta blockers on both heart rate and the physical components of quality of life. However, digoxin had considerably better symptom improvement, a reduction in natriuretic peptides, and much lower rates of adverse events without any compromise in left ventricular function. Our results suggest a wider use of digoxin for stable patients with permanent AF and reiterate the need for randomized controlled trials to advise on treatment decisions. I'd like to thank the team that helped to design and run this trial, the patients who offered their time and well-being, and our funders at the National Institute for Health Research. Thank you very much.
Comentarios, doctor Mitre, de que casi tira la digoxina ahí por la ventana y la avienta al suelo y la pisa. ¿Qué les pareció, Poncho, Miguel, Galicia, Eric, Ricardo?
Pues bastante interesante. Como dice doctor, ya habíamos, bueno, en la guía previa a esta reciente que salió, la recomendación era solamente para el control de la frecuencia cardíaca en pacientes con fracción de eyección disminuida, ¿no? Y aquí parece que ahí en las tablas mostraron fracciones de eyecciones de 56% por ahí, y cómo mejoró pues los síntomas. Parece que la clase funcional pues mejoró también con la dioxina. Ahí pues no había muchas diferencias entre el uso del beta bloqueador con la del digitálico. Entonces pues sí, que esto nos muestra que sí tiene cierta utilidad. Incluso ahí al final ponen que pudiera utilizarse como una primera línea de tratamiento para el control de la frecuencia cardíaca en los pacientes con fibrilación atrial permanente.
Muy bien. ¿Algo más? Vamos a buscar esta diapositiva. Parece que fueron 60 pacientes de 60 años o más. Y ejection fraction exclusion apart from recent descompensation. Ok. Sí. Ricardo, ¿qué vas a decir?
Nada, lo que ya hemos platicado, la dioxina pues, se niega a morir y va a estar con nosotros, y aquí hay más evidencia. Aquí no fue inferior al beta bloqueador, o sea, todos los beneficios que nos está poniendo aquí en cuanto a la calidad de vida, hospitalizaciones, valores bioquímicos del BNP. Entonces, pues yo creo que tenemos dioxina todavía para rato y con más evidencia.
Sí, fueron 161 pacientes. Parecía ser así como que medio poquito. Aunque su punto final primario de análisis, no sé cuál fue el punto final primario, pero bueno, aquí a lo mejor habrá que replicarlo en estudios más grandes.
Sí, pero probablemente también influya en que no sé qué tanto a los laboratorios les retribuya estar haciendo estudios con digoxina. No sé también si por esa razón no se haya hecho estudios grandes o se vayan a hacer.
Perfecto, sí, y otra cosa es la dosis que utilizan, ¿no? Utilizan una microdosis, es decir, no utilizan, bueno, utilizan de las tabletas de 0.25, utilizan ellos como media tableta,
pues como la
¿no?
mitad, eran 161
Sí,
la media, entonces es una dosis muy, muy baja, y aún así logran un muy, muy adecuado control de la frecuencia.
Sí.
¿O será que nuestros pacientes que tienen digoxina a esas dosis, también haya diferencias en cuanto al metabolismo? No sé si eso sea parte de lo que se ha estudiado en el hospital o en el posgrado que ha hecho estudios con digoxina.
Sí, en el que participó ahí ustedes, Poncho con Paulina, solamente se estaba viendo en cuanto a niveles séricos, qué tanto estaban, fue el único así como que punto a analizar, ¿no? O sea, qué tanto estaban dentro de los rangos terapéuticos marcados mediante los niveles que se consideran terapéuticos, pero fíjense como aquí ni siquiera se guiaron por eso, o sea, no están midiendo cuál es el nivel de digoxinemia, ¿no? Nada más hacen el seguimiento y empiezan a ver estas diferencias. Perfecto, muy bien. Poncho, ¿algo que quieras decir? Ya se durmió. Bueno, vamos a ver todavía nos queda un poco de tiempo y ya este es el último, ¿sí? Ahí va.
Atrial fibrillation. This is my declaration.
A wider use of digoxin for stable patients with permanent AF and reiterate the need for randomized controlled trials to advise on treatment decisions. I'd like to thank the team that helped to design and run this trial, the patients who offered their time and well-being, and our funders at the National Institute for Health Research. Thank you very much.
Hello, my name is Shovik Haldar. I'm a consultant cardiologist at the Royal Brompton and Harefield Foundation Trust, London, UK, and Imperial College London, UK. I'm delighted to present this study of ours at the ESC Congress 2020, The Digital Experience. The study is a multi-center randomized control trial comparing catheter ablation versus thoracoscopic surgical ablation in long-standing persistent atrial fibrillation. This is my declaration. Long-standing persistent atrial fibrillation patients are a challenging cohort of patients to treat with catheter ablation. Single procedure outcomes are modest, and patients often require multiple procedures to maintain normal sinus rhythm. In recent years, there have been several randomized and non-randomized studies looking at thoracoscopic surgical ablation as an alternative approach, and there has been signs of promising efficacy. However, these studies are difficult to interpret because many patients included had prior unsuccessful catheter ablation. They included many mixed populations of atrial fibrillation. There was considerable lesion heterogeneity within the studies, as well as inconsistent verification of conduction block, and a variety of different ECG monitoring techniques used to look for recurrence. Our rationale for our study is the fact that long-standing persistent atrial fibrillation is a significant evidence gap in the literature, and this is well recognized in international guidelines. What is the optimal interventional first-line strategy for long-standing persistent AF is unknown. There is also a lack of studies focusing on a uniform patient population such as long-standing persistent AF, and there is a general need to compare data surgical versus catheter ablation in atrial fibrillation. There is also a need to look at ablation outcomes and relate them to quality of life and patient symptoms. And therefore, our study objective was to determine whether thoracoscopic surgical ablation was superior to catheter ablation as a first-line procedure in drug-refractory, de novo, long-standing persistent AF patients. We compared the effectiveness thoroughly using an ILR, which allowed us to do continuous cardiac monitoring. We also looked at safety, the impact on patient symptoms, quality of life, as well as cost effectiveness between the two treatments. The study design essentially was when patients were eligible for the study, they became randomized in a one-to-one fashion, having been stratified according to gender and left atrial diameter. At the index procedure, at the end of the ablation, they had an implantable loop recorder implanted, and after a blanking period of 3 months, they were followed up at 3, 6, 9, and 12 months. The inclusion criteria essentially was adults with long-standing persistent AF with an ERA score of greater than 2, preserved left ventricular function, and suitability for either procedure. The exclusion criteria included significant valvular heart disease, prior catheter ablation for atrial fibrillation, and prior cardiothoracic surgery, amongst others. When designing the study, we tried to make the lesion sets as comparable as possible, despite the two different approaches of the techniques. For catheter ablation, we undertook pulmonary vein isolation, posterior wall box lesion, a mitral isthmus line, and a cavo-tricuspid isthmus line. For surgical ablation, we undertook, again, pulmonary vein isolation, posterior wall isolation, but this time the addition of ganglionated plexi ablation, ligament of Marshall transection, and left atrial appendage exclusion. In terms of the primary endpoint, we followed HRS guidance in that we used a single procedure, freedom from atrial arrhythmias of greater than 30 seconds without antiarrhythmic drugs during the 12-month follow-up. We had many secondary endpoints, including a safety endpoint of procedure-related serious adverse events, clinical success as determined by a reduction in atrial arrhythmia burden of more than 75%, changes in patient symptoms, changes in quality of life score using a disease-specific score, affect, and a non-disease-specific score, EQ5D. We also looked at within-trial health economic assessment using quality-adjusted life years and UK healthcare costings. In terms of baseline characteristics, the two groups were comparable. The age was early 60s, male sex predominated, BMI was elevated, ejection fraction preserved, left atrial diameter enlarged. The duration of persistent atrial fibrillation was 2 years and below. In terms of procedural characteristics, we see that the surgical ablation took longer. However, the ablation time was shorter in surgical ablation, and which is a manifestation of the fact that different RF tools are used between the two techniques. One advantage of surgical ablation is that no X-ray is used. However, the length of inpatient stay for surgical ablation was significantly longer at 6 days versus 2 days for catheter ablation. Now to the primary and secondary endpoint in terms of arrhythmia recurrence. The left panel shows the Kaplan-Meier curve of the primary endpoint, freedom from atrial tachyarrhythmia greater than 30 seconds. We see that at 12 months, 26% of patients in surgical ablation group are free from atrial AF or AT, and 28% of catheter ablation. And that is statistically not different. In terms of the clinical success on the right panel, in terms of AF-AT burden reduction of greater than 75%, we see much higher success. So 66% in the surgical ablation arm and 77% in the catheter ablation arm. And one may argue that this is more pertinent for the patient perspective. Again, the result was statistically not different. With regard to procedure-related serious adverse events, in the study, our serious adverse events were much lower than in previous studies. Numerically, there was no significant difference between the two groups. However, surgical ablation, one must note that there was a death and that overall there were more respiratory-related complications in the surgical arm. In terms of other important secondary endpoints, we see that catheter ablation patients had a greater AF symptom score reduction. They also had a greater quality of adjusted life year gain, and catheter ablation was less costly than surgical ablation. So how does our study fit in with previous randomized control trials in this arena? There were 4 previous randomized control trials in the last decade. Adiaman et al. In 2018 did a non-inferiority study where they had a mixed cohort of patients with a very long recruitment time and a small sample size, and they showed that surgical ablation was less effective than catheter ablation. Wang et al. In 2014 looked at exclusively paroxysmal atrial fibrillation, where one might argue that surgical ablation is not a routine recommendation in this cohort. However, they undertook monitoring using ECG and Holter and showed that surgical ablation is more effective than catheter ablation. Pokshalov in 2013 looked again at a mixed cohort of patients, all of whom had failed initial catheter ablation. It was a small study size, and again they found that surgical ablation was superior to catheter ablation. And finally, the Bersma study, well known as the FAST study, again looked at a mixed cohort of patients using ECG and Holter for recurrence monitoring and found that surgical ablation was again superior. Our study is the first multi-center randomized control trial looking at de novo drug-refractory long-standing persistent atrial fibrillation, and we found that thoracoscopic surgical ablation was not superior to catheter ablation in establishing and maintaining normal sinus rhythm in this group. We also found that catheter ablation was associated with greater improvements in symptoms and quality of life and was more cost-effective than surgical ablation. We therefore recommend catheter ablation as the first-line interventional therapy for patients with symptomatic long-standing persistent atrial fibrillation refractory to drug therapy. We'd like to acknowledge the National Institute of Health Research for funding the study, our chief investigator, Dr. Tom Wong, and our trial manager, Dr. Ines Krantz-Hans. Thank you for listening, and I'd like to leave you with an infographic summarizing our key findings from the study. Thank you for listening, and I'd like to leave you with an infographic.
Bueno, comentarios, residentes.
Bueno, pues aquí en este estudio nos muestran cómo nuevamente estas técnicas de ablación con catéter parecen ser pues una estrategia a considerar incluso como primera opción en este tipo de pacientes que tienen una fibrilación auricular de por lo menos 12 meses de duración, que no ha respondido a tratamiento médico. De igual forma ya previamente ya venía esa recomendación, pero no con tanto peso en las guías previas. Entonces, pues es importante saber que quizás de ahora en adelante lo que la tendencia va a ser al estudio o a la ablación con catéter, más que el procedimiento quirúrgico.
Sí, creo que lo único que ofrecería ahorita en un procedimiento quirúrgico, obviamente es con toracoscopía. Antes se tendría que hacer en cirugías abiertas, ahora son toracoscópicas, son cirugías menos invasivas, obviamente. Y bueno, en este estudio demuestran que en estos aspectos que están señalados acá abajo, pues es preferible hacer una ablación con catéter de fibrilación auricular ya establecida, ¿no? Una parte importante, fíjense aquí abajo, es cómo en los otros estudios, cómo hacían el diagnóstico de una recurrencia de fibrilación auricular, que era con electrocardiograma y Holter. Ya en este estudio y en otros están utilizando los monitores implantables, ¿sí? Para los registros de si recurre o no a la fibrilación auricular. Muy bien. Ricardo, Poncho, ¿algún comentario?
Sí, doctor, bueno, pues aquí vemos nuevamente el alcance del intervencionismo. Cada vez pues, hay más procedimientos en muchos campos de la cardiología misma, de la medicina y la cardiología, que le están ganando terreno a la intervención con eficacia pues, al menos igual, o sea, al menos no son inferiores y en algún caso muy superiores, menos efectos adversos. Menos complicaciones y menos días de hospitalización. Entonces, pues es algo a lo que ya estamos acostumbrados pues, a ver, de que ya lo quirúrgico en muchas ocasiones es una segunda opción.
¿Y en quién indicarías tú, Ricardo, una ablación de una fibrilación auricular ya establecida, permanente? ¿A quién mandarías a que le hicieran una ablación de FA?
Anticoagulante.
No se escuchó bien, Ricardo. Bueno. Bueno, ya no se escucha bien, pero sí, creo que por ahí va el comentario de Ricardo de pacientes que tienen alto riesgo de sangrado, aunque sabemos que también para eso se ha
La
desarrollado.
articulación que estaba...
No.
¿Perdón?
Sí, es que no te escuchamos bien. Bueno, no te escuché bien, Ricardo. El tipo de paciente que mandarías.
Decía que igual pacientes que por alguna razón no pueden tener una anticoagulación completa u óptima, y también de acuerdo a la valoración que hacemos con las escalas de los riesgos de sangrado, y en un paciente que no podemos anticoagular, riesgo alto, pues tal vez es a quien llevaría el procedimiento.
Sí, claro, también, por ejemplo, pacientes que están muy sintomáticos, que no podemos controlarles bien la frecuencia cardíaca, que por la misma FA rápida pueden estar desarrollando daño miocárdico como una miocardiopatía, ¿verdad? O que les hemos dado tratamiento que el estudio previo nos diría que digoxina pudiera ser, o juntamos ya varios medicamentos, incluyendo hasta gabardina, se llega a utilizar. Y no podemos controlar la respuesta ventricular, ahí yo creo que sería otro caso también importante considerar la ablación, ¿no? Algo que ofrece lo quirúrgico es la oclusión de la orejuela, ¿no? A diferencia de los catéteres, de la ablación con catéter. ¿Ok? Bueno. Muy bien, jóvenes, aquí le dejamos.
Sí.
Mañana es día festivo, el jueves seguimos con esto. Yo creo que podemos agotar estas pláticas que en realidad están muy buenas. Les digo, estamos en el mes en donde nos tocaría ritmos, entonces creo que podemos seguir con esto. Y quedaba pendiente la clase de Poncho, que yo creo que la podremos revisar el viernes a las 7 de la mañana. Ya para terminar lo de intervencionismo. Bueno, muy bien. Estamos en contacto. Gracias.
Hasta luego.
Bye. Gracias.
Bye.
Bye.